Okay, so let's say a patient comes to the office and they have, you're going to hear very often the term estrogen dominance. We, over the last 40 years, have noticed such an increase in diseases related to estrogen dominance, fibroids, endometriosis, breast cancer, fibrocystic breasts. So many diseases now seem to be more prominent, and it appears to me, and I'm sure that you'll give his opinion as well, that since we've introduced HRT and birth control pills, and we have used it so commonly, and perhaps in reflection we should have stepped back and maybe reflect again on who we give hormones to, and perhaps they have a role. In my practice, I don't use synthetic HRT, I use bioidentical hormones if I need hormones, and I have so for the last 15 years. I haven't written a prescription for Prem and Provera for 15 years, and birth control pills I used to use more commonly. I use them less commonly. I know that Yoel uses them more than I do. But once again, I'm sure someone like Yoel would take a good history and would probably not give everybody a panacea birth control pill without giving a great deal of thought to it. Perimenopause is the 5 to 10 years that the patient will go through before they go into menopause. Menopause itself is only a definition of 1 year without a period. If you go 10 months and then have a period at the age of 49, 52, 56, whatever it is, you're not in menopause. And so blood testing can be a deceptive thing. Doing an FSH, follicular stimulating hormone, over 40 is suggestive of menopause, but the only true definition of menopause is 1 year without a period. In North America, over the next 20 years, every 10 seconds, a baby boomer is going to go into menopause. Physician, prepare thyself. This is not a group you can pat on the head and say, now, my dear, I'll take care of everything. They pat you on the head and leave the office. They have actually told me, my patients are very skewed towards being very outspoken, but they'll hand prescriptions back to the physician and say, give this to your wife, or why don't you take this yourself? And usually the physician's left with their mouth open. So these symptoms that you see here are so common, and yet they have a common thread. And the common thread usually is what I call estrogen dominance. When a woman produces estrogen, as you menstruate, the estrogen is very low. And as estrogen starts to rise, if the uterus is this room, the wall get thicker and thicker. And what happens in perimenopause, if you understand the physiology of real reproductive cycles, as estrogen makes the lining thicker, along comes mid-cycle progesterone and is secreted as ovulation and packs down the lining, kind of makes it a little bit more firm, and is a timing mechanism to wait for a pregnancy. If there's no pregnancy in 14 days, then menstruation. So if someone is having irregularities in their periods, it's usually because the lining is not getting the message that we always got. So if the lining gets thicker and thicker and there's no progesterone, she's not ovulating at 42 or 43 and she misses a few periods, the lining can get too thick and she can hemorrhage or she can have breakthrough bleeding. And these are the beginnings of perimenopause. Anxiety occurs in perimenopause and PMS patients for the same reason. What happens is most women have what I call a threshold of estrogen. Everybody has kind of a different level they can handle. For example, if you were nauseous in pregnancy or nauseous on the birth control pill, what happens is as the estrogen rises up and towards mid-cycle, progesterone is then secreted and knocks estrogen back down. If you have estrogen rising, the next book should be called Estrogen Rising. As estrogen rises and there's no progesterone, the body panics because the body doesn't like anything too high or too low. The body secretes adrenaline and noradrenaline, anxiety, irritability, insomnia, heart, chest pain, breast pain, all from a prominence of high estrogen, but adrenals pouring out adrenaline and noradrenaline. As adrenaline and noradrenaline is secreted, you need to use dopamine and serotonin to make the adrenaline, noradrenaline. So then by the end of the cycle, you have PMS and the patient's weepy. But you can actually treat a lot of these symptomatologies understanding the physiology, because if estrogen is so potent, the patient's own estrogen is impotent. I'm impotent, I'm going to dress impotent. If estrogen is very, very high, I'm telling you right now that you can compete with your own estrogen. You can actually take phytoestrogens. And understand that's not a word, that's a bad word. If you have breast cancer, people say, oh, I can't take any estrogen. You can take phytoestrogen. These are plant-based estrogen. Black cohosh, donquay, evening of primrose, but these are all phytoestrogens. And why are they important? Because if a receptor is looking for estrogen and your own estrogen hits it, to me, you're better off if it's protected with a phytoestrogen, with a weak estrogen. Far better than getting a xenoestrogen from the environment, which is 10 times more potent than your own estrogen at that receptor site. So taking phytoestrogens actually can treat PMS and irritability, insomnia. Acne, for example, is coming from the adrenals. When I say the adrenals have to do their role, well, if progesterone isn't there, progesterone has a whole list of enzymes and biochemical reactions that it must do. If progesterone is not secreted, the adrenals feel that they have to do the job. So the adrenals hypersecrete, as I told you, and produce too much male hormone, because DHEA is an adrenal hormone that leads to testosterone. And once you get testosterone in a woman or a man, testosterone can be get out of the body through estrogen, or it can go a pathway to called dihydrotestosterone, which is 10 times more potent. In a man my age, prostate enlargement. In a woman, acne, hair loss. So what would a woman use if they had acne and hair loss? Saw palmetto. We would block the transformation of your testosterone into dihydrotestosterone and allow you to make normal estrogen. Women have testosterone. Men have 10 times as much testosterone as you do. That's why we don't need a reason to fool around. We just need a place to fool around. But testosterone is a very important hormone in men and women. So andropause in men and menopause. We'll talk about menopause replacement of testosterone. We'll get into more of the menopausal symptoms in a second, I think. Exercise, we mentioned, one of the things, statistics is 3 hours of exercise in a week, you decrease your incidence of breast cancer by 50%. 50%. We mentioned supplements already. Noel mentioned the calcium, magnesium. I always like to have a balance between 1-to-1 ratio of those two, now using vitamin K as well.
I think the other important thing, and this is how I think it's very important to recognize the importance of balance. And you know, in the past we said no sunshine, and now we've come around to recommend at least 20 minutes, at least again in the temperate climates where we become, all of us, men and women, become vitamin D deficient through the winter. They're recommending now 20 minutes of unprotected, that is no sunscreen, sun exposure.